Hello everyone, my name is Monique Jefferson and this is my project on reducing restraints in the CSICU for Maryville University. Upon completion of this learning experience, we will discuss characteristics of the CSICU patients restrained in 2019 through a retrospective study. We will examine the current practices at Carilion for restraint policy, documentation, and assessment tools, and identify strategies to reduce the incidence of restraint application. Objective 1. There is a lack of evidence that restraints prevent harm. Consequences of physical restraint have been well documented and include increased agitation, increased risk for delirium, PTSD, pressure injuries, damage to limbs, and even death. The Cardiac Surgery Intensive Care Unit, or the CSICU, has failed to remain below the NDN-QI benchmark for at least 1/4 of each fiscal year since 2016. That's 2016, 17, and 18. Literature supports that educational interventions were successful in significantly decreasing restraint use without an increase in patients removing vital lines and tubes. The NDN-QI, or the National Database of Nursing Quality Indicators, is the only reporting program that provides performance comparisons on a unit level. They rank similar hospitals across the nation and even overseas. This data is used to improve hospital performance and patient outcomes. The NDN-QI measures these categories in 4 quarters out of every year. For the CSICU, we have failed 1/4 in 2016, 17, and 18. The purpose of the study is to reduce restraint use consistently below the NDN-QI benchmark. Both Carilion Medical Center and the Maryville University IRBs have deemed this project QA-QI. It is a quantitative exploratory design through retrospective chart reviews. EPIC was utilized to access EMRs of patients receiving care in the CSICU during the specific time frame. Data was extracted by the HEART team and by myself, the co-investigator, through manual chart reviews. The PCOT question is, in the CSICU, will an educational intervention on the characteristics of restraint encounters in the CSICU decrease restraint rates below the NDN-QI benchmark? Data of the patients who were restrained in the calendar year 2019 were extracted and were analyzed. Let's get into the characteristics of the restraint encounters. There were 135 admissions that correlate to 132 unique patients that were restrained in the CSICU during the 2019 calendar year. This is because 3 of those patients were admitted more than once. And we can see the breakdown of the total between males and females. 28% were females and 71 males. We can see the age range for females and males and the length of stay average for males and females. Quantitative methods were used for the type of restraint, location, if there were multiple restraint episodes on one patient, presence of an ET tube, the CAM scores and the Moore scores closest to the time of application of the restraint, and the least restrictive methods that were used before the application of the restraint. Majority of the encounters utilized soft wrist restraints, about 98.5%. The remainder of the restraints used were hand mitts. There were no use of vests in our unit in the 2019 calendar year. 8.9 of the soft wrist restraints were applied to the ankles, while majority, 97%, were applied to the wrist. Several of the patients had multiple restraint encounters. 36 out of the 35 encounters, or about 26.7%. And most patients who got restrained were also intubated, about 110 out of 135. Most of the CAM-ICU scores were surprisingly negative closest to the time of restraint application, about 50 out of 135, or 37%. Only 13% had positive CAM-ICUs, and the remainder were unable to assess. There were 39 encounters that did not have a CAM-ICU score documented. The Moore scores range from 20 to 95, with a maximum of 95 and an average of 50. There were 3 Moore scores not documented on. The least restrictive alternative attempts are displayed here, with alarms, one-to-one care, reorientation, repositioning being utilized the most, while alternatives such as family presence and lighting were being utilized the least. In summary, a majority of the patients restrained in the CSICU were male, intubated, in their mid-60s, with a negative CAM-ICU closest to restraint application and an average Moore score of 50 closest to time of restraint application. The mean length of stay was 18 days, with alarms and one-to-one care utilized the most as alternatives to the application of restraints, and soft wrist restraints were applied most frequently to the wrist. Moving on to Objective 2. The Carilion Clinic Restraint Policy. In page center X, it's titled Restraints/Seclusion, use of. It was just updated in May of 2020. It has the restraint and seclusion decision flow sheet, which will go over restraint orders and alternatives to restraint applications and the required documentation. So this is the restraint flow sheet in our current policy to help aid in deciding if a physical restraint is necessary. Note most of the restraint encounters in the CSICU are nonviolent, non-behavioral, which is the column over to the far right. Restraint policy on orders. A provider must be notified if a restraint is applied. Most often we use non-behavioral restraints to protect equipment. Behavioral is more common on the psychiatric floors, but we must be aware of the policy and procedure on applying both types. Now you see for behavioral, the length for 18 years or older are 4 hours. From 19 to 17 is 2 hours, and under 9 is an hour. Manual holds are 15 minutes. Non-behavioral, what we are used to dealing with, are 24 hours. And just don't forget that the provider must be notified. Policy on monitoring. Always assess if the restraint can be discontinued or if an alternative method would be effective. Document on restraints under the restraint flow sheet in EPIC every 2 hours for non-behavioral restraints. Now you see for the behavioral, it changes. Monitor frequency every 15 minutes, assess the need for the restraint every 2 hours, and the documentation on that is every 15 minutes, not every 2 hours. But like I said, we are accustomed to non-behavioral, so we basically chart and assess our need and monitor every 2 hours. So the policy on alternatives to the restraint. In the policy, you will see a list of things that you can try before you actually place the restraint on the patient. As discussed earlier, we know that there is documentation of application of restraints causing agitation, delirium, PTSD, and even death, and that the literature supports educational interventions to reduce the application of restraints without increasing the incidence of patients removing vital lines and tubes. Next, we will discuss the non-behavioral restraint documentation, which is what we are accustomed to in the CSICU. Now we'll use some sandbox charts to exemplify how restraints should be documented. The time of the restraint order and the first documentation of the restraint should be exactly the same. If the restraint order is put in at 12, then we insert a column and put a restraint charting in the flow sheet at 12, as you can see the green arrow. For the very first documentation of the restraint, this whole entire column needs to be filled out. Now this is just continuing on of the same column, but like I said, for the very first time that you are documenting on the restraint, you fill in that entire column, which goes all the way down, as you can see, to vital signs. Now during the manual chart review, it was found that there was a considerable amount of incorrect documentation on restraints in EPIC, especially with the start, discontinue, renew documentation. So you see under restraint type, non-behavioral, it says it must match the order. And so if this is the first documentation, we will choose start under the correct restraint. If they have wrist restraints, that's where we're putting the start. If it's ankle, that's where you put the start, mittens, no, so on and so forth. Now, if the restraint is being discontinued, you choose the right one, wrist restraints, mittens, ankles, and you put discontinued. So now if the order was already in place, and it's the next day because they only last 24 hours, and this is order renewed. Whichever time the order was renewed, you insert a column for that time, and then under the correct restraint, whether wrist, ankle, whatever, you put order renewed. Now, if this is your every 2 hour documentation and you're continuing under the same order, you do not have to fill in this area under restraint type, non-behavioral, much match order. You can, if you would like to, go into the little note box and hit continued if you would like. Now that we've gone over the very first documentation or the initial documentation after you receive an order, after that, we typically do our documentation every 2 hours on the even hour. So you can see our order started at 12. We filled in the exact time that the order was written. We put a column in for there. We filled in that entire column. And then the next time 2 hours hit, typically on the even hour, we only have to fill in the restraint assessment, the 2 hour non-behavioral restraint assessment, where it asks you for continued need for restraint. And then it asks you for the 2 hour monitoring, where you go into the physiological status, circulation, respiratory, down to hygiene. So after the initial documentation of the restraint, the Q2 hour documentation, which is typically done on the even hour, you only have to fill in the continued need for restraint through the monitoring down through hygiene. Now that's all you need to do every 2 hours until your restraint is either discontinued or the order is renewed. Now we'll go over some assessment tools. Now when we're charting in EPIC, there are several assessment tools that we can use to help assess our patients. In EPIC, the assessment tools will have scoring criteria in the box over to the right, or there will be a hyperlink, such as shown here with the Richmond Agitation Scale. So if there's a hyperlink over to the right, you can click the hyperlink, and as for the Richmond Agitation Sedation Scale, we clicked on that hyperlink, and this is the box that will come up to show you the criteria and how to use the scale appropriately. Now here's another example for one of the assessment tools and how that information can open up for you in a different window. Here we have the CAM ICU in the flow sheet. Now if you're in that section, over towards the right, there will be a hyperlink because there's just too much information to put in that little column right there. The hyperlink will then open up the window for the CAM ICU, and that will display the algorithm so that you know how to accurately score a CAM ICU. ICU delirium is a leading cause of restraint use, so it's key to understand how to use these tools accurately. Remember, a positive CAM ICU must have features 1, 2, and 3, or features 1, 2, and 4. So all the tools that are available to us in EPIC will either have the link over in the right sidebar because there's too much information, or their criteria will just populate there, such as for the BMAT and the Morse score. Objective 3. So here are some strategies to help reduce restraints application. Remember, all appropriate least restrictive methods should be tried before applying the physical restraint. And I also want to note that for us in the CSICU, post-op patients who are in that 6-hour window and that need to be restrained, those don't count towards our numbers. So don't think that I'm talking about those patients who need a restraint immediately post-op. As long as they are extubated within the 6-hour window, those restraints are considered part of the medical procedure, and they do not count against us. These are other patients that I'm talking about. So we can always use our pain management and review and bed alarms, chair alarms, one-to-one care, sitters, walk them, talk with them, sit with them, have them watch some Get Well Network videos, disguise equipment, and things of that nature to help prevent the need for the application of the restraint. A lot of times they just need to be kept busy. Continuing on with the strategies to reduce, we can decrease the stimulation. Daytime is daytime, nighttime is nighttime. Answer the call bells, hit those alarms. Don't just let them continually go off. I know alarm fatigue is very real, but we need to answer these alarms and bells swiftly. Keep the noise level at the nurse's station down. Relaxation, those eye kits with the earplugs and the masks. The Get Well Network with the calming scenes and the music. Location, do they need to be moved so that everybody can see them from the nurse's station? And family, we are having more and more family coming to visit now with COVID, lifting just a little bit, and you need to use your judgment. We are not to use family to watch our patients, but sometimes their presence can be calming to the patient. You just use a case-by-case judgment. So in summary, majority of the 135 encounters for that 2019 calendar year in the CSICU of restrained patients were male, intubated in their mid-60s with a negative CAM ICU and an average Morse score of 50. One-to-one care and alarms were utilized the most as least restrictive alternatives to the restraint. We used soft restraints the most, and they were most frequently applied to the wrist. And a mean length of stay for those patients were 18 days. So here were some gaps in the documentation that were found through the chart reviews. 39 out of the 135 encounters did not have a CAM ICU documented. The CAM ICU should be documented at least once a shift and when there are changes. You can go back to slide 28 to see the scoring criteria for the CAM ICU if you have questions on that. 3 out of the 135 didn't have a Morse score documented. This also should be done once a shift or when there are changes. The initial restraint documentation should be at the exact same time as the restraint order. You have to insert a column to do this if need be. After that, the every 2-hour restraint documentation only requires documentation on the continued need for the restraint in the 2-hour monitoring section, as shown previously in the slides. And here are just a few documentation reminders of your restraints. Under the restraint type, when you do the first documentation, you choose the correct restraint type, wrist, ankle, so on and so forth. And if it's the first documentation, you choose start. If they're being discontinued, you choose discontinued. If they're being renewed, you insert a column for the time of the renewed order, and you put in order renewed under the correct restraint. Now, if you're continuing on this 2 hours under the same order, you do not have to chart under there. You can leave that blank, but if you would like to, because there's not an option for it, you can put into the note continued. Here are just some takeaways from the project. Identifying these patients lets the nurse know who is at higher risk for restraint application and can try to identify these patients and intervene earlier to prevent the restraint being needed. Timely and accurate documentation in EPIC is crucial to understanding how our unit is performing, so we have accurate numbers so that we can continually improve. We do very, very well in the CSICU, and we're only missing 1/4 out of 4 each year, so let's get to 100%. And I would like to give some acknowledgments and thanks to everyone who worked on this project or supported it. Our clinical nurse specialist, Kathy Jennings, our senior director of nursing research, Kim Carter, the heart team, especially Mariana Solomon and Tanya Locklear, Christina Massey, the CSICU unit director, and my DNP chair, Elizabeth Buck from Maryville University. Thank you all.